Hello everybody, today we are going to talk about lung cancer. So lung cancer encompasses all malignant tumor originating in the bronchial and bronchopulmonary area. It's a really big public health problem because of the bad prognosis. It is the first cause of death by cancer, but it is accessible to prevention because of the main risk factor is smoking. The average age of onset is 62 years, but nowadays we are seeing more younger people having this cancer. According to the World Health Organization, in 2018, the incidence of this cancer was 2.1 million new cases per year, and the mortality 1.8 million deaths per year, with a survival all stages combined less than 20% at 5 years. In Morocco, according to a registry that we have in Casablanca in 2019, the incidence was 25.5 new cases per 100 million men, with 5,594 cases in 2019. Only 4% of cases were diagnosed at an early stage, stage 1 or 2, and 96% were diagnosed at late stage, metastatic stage, stage 3 and 4. We noticed that we have an increase in the proportion of women who are smoking, and it overcame the breast cancer since 1987. We have a stabilization or even a decrease in its incidence in developed countries, which have started anti-smoking campaigns from over 30 years. But we have an increase of its incidence in the overpopulated countries and developing countries like China, India, and our countries also. As we have said, we have a rejuvenation. We are seeing more and more young people having that cancer. What about the risk factors? The major one, of course, is smoking, and the active smoking is responsible for 85 to 19% of the cancers, lung cancers. The overall relative risk is multiplied by 15 to 20 if we compare it to a non-smoker patient. We have several carcinogens in the tobacco smoke, and the most important risk factors is the early age of onset and the duration of smoking more than the amount of cigarettes smoked per day. After stopping smoking, we have a decrease of the risk, but we never return to a situation like a non-smokers. Also, the passive smoking can be responsible of lung cancer, especially if we have passive smoking since childhood, and it is responsible of 25% of lung cancer in non-smokers. So, the first risk factor, the major one, is smoking. The second one is the occupational exposures, which is the exposure in our work. It is often underestimated because often we have these patients who are smoking, and we relate the lung cancer to the smoking statue more than the exposure. It is responsible of 20% of lung cancer, and the first cause of this cancer is the exposure to asbestos. Other risk factors are silica, iron, foundry, and hydrocarbons. Also, we did notice that we have a high number of lung cancer in the industrialized area, so the air pollution is responsible of lung cancer. What about the oncogenesis? So, the carcinogenesis evolves over several stages. We have a series of genetic alterations that are responsible of the activation of oncogenes and the inactivation of tumor suppressors. we could have a lot of mutation in the same patients, and in some cases we have only one oncogene mutations, and we are speaking at this time about oncogenic addictions. And the most important oncogenic addictions that are known are EGFR, BRAF, and ALK, and ROS1. And we are always looking for these oncogenic addiction while doing our biopsy, because they are targeted treatment that we can give to these patients. So these addictions are seen especially in non-smoking women with adenocarcinoma. What about the anatomopathology of these lung cancer? As we can see, we have dozens of types, subtypes, anatomopathologic subtypes, but only 4 that are the main histological types that we see in the practice. The first one is the squamous cell carcinoma, or what we call in French carcinome épidermoïde. It is a non-small carcinoma showing signs of keratinization and or intracellular bridges. It reproduces the differentiation of the Malpighian epithelium. It is a classic smoker's cancer, most often manifests as a proximal endobronchial bud accessible to fibroscopy, so it is proximal, it is near the hilum, and it may be excavated by central necrosis. The second one is adenocarcinoma, or what we call in French adenocarcinome. It has a glandular differentiation or presence of signs of mucin productions. It is often peripheral, which is different from squamous cell carcinoma. It's present like a parenchymal nodule, more rarely a proximal mass. It has some histological subtypes like mixed, acinar, papillary, bronchoalveolar, or what we call now lipidic, and solid with mucin production. The problem with adenocarcinoma that we have to know if it is a primary pulmonary adenocarcinoma or metastatic adenocarcinoma from elsewhere, from the digestive tract or other way. The third one is small cell carcinoma, or what we call in French carcinome à petites cellules, le CPC. It is responsible of 15% to 20% of all primary bronchial cancers. It has a neuroendocrine origins with a very fast doubling time. It is the most bad cancer, lung cancer, with a very high metastatic power. The immunohistochemistry help us to have that diagnosis, because the histological definition is the small cells, family glandular chromatin with high mitotic index, and in the immunochemistry we have to have chromogranin and synaptophysin. Those tumors are proximal, have the proximal development with hilar and even a mediastinopulmonary extension. And the last one is large cell carcinoma, or what we call in French carcinome à grande cellule. As we have said, we have the most important anatomopathological subtype is the non-small cell lung carcinoma, and especially squamous cell lung carcinomas and adenocarcinomas, and then small cell carcinoma cancers, which are responsible of 10 to 15% of lung cancer, and of course we have other subtypes.